Anticoagulation in patients requiring antiplatelet therapy is a high-stakes balancing act between preventing life-threatening thrombotic events and minimizing the risk of catastrophic bleeding. This is particularly relevant for patients with atrial fibrillation, venous thromboembolism, mechanical heart valves, or left ventricular thrombus. These conditions necessitate oral anticoagulation, but also require antiplatelet therapy due to acute coronary syndrome or percutaneous coronary intervention. At the heart of the issue is the need to tailor therapy based on individual thrombotic and bleeding risks. Dual antiplatelet therapy, consisting of aspirin and a P2Y12 inhibitor, is standard after PCI, but adding an oral anticoagulant, whether warfarin or a direct oral anticoagulant, dramatically increases bleeding risk. Evidence from major trials has reshaped management strategies. Studies show that a dual pathway approach, combining a P2Y12 inhibitor with an oral anticoagulant, reduces bleeding compared to traditional triple therapy, which includes aspirin. Importantly, this streamlined regimen has not demonstrated an increased risk of thrombotic events, though individual trials have been underpowered to detect small differences in ischemic outcomes. For patients with atrial fibrillation undergoing PCI, a stepwise approach is recommended. Those with a low stroke risk, CHADS2 of 0 and age under 65, may forego anticoagulation and follow a standard dual antiplatelet regimen. However, for those at higher stroke risk, a short course of triple therapy is advised, with aspirin discontinued as early as 1 day post-PCI in high bleeding risk patients, or continued up to a month in those at higher thrombotic risk. For patients with venous thromboembolism requiring PCI, the goal is to ensure adequate anticoagulation while minimizing bleeding. If feasible, elective PCI should be deferred until the acute VT period has passed. When anticoagulation is needed long-term, dose reduction strategies, such as low-dose rivaroxaban or apixaban, may be considered alongside antiplatelet therapy. In the case of left ventricular thrombus, data on optimal management remain limited. Direct oral anticoagulants may be a reasonable alternative to warfarin, though most studies suggest using full therapeutic doses. The same principle of early aspirin discontinuation applies, with decisions individualized based on bleeding and thrombotic risks. Patients with mechanical heart valves represent a unique scenario where warfarin is the only recommended anticoagulant. Triple therapy is initially required post-PCI, with aspirin discontinued at 1 to 6 months, again depending on risk assessment. For patients with stable cardiovascular disease, recent evidence from the COMPASS trial supports a low-dose rivaroxaban and aspirin combination to reduce cardiovascular events. However, the associated increase in bleeding risk underscores the importance of careful patient selection. Ultimately, managing patients who require both anticoagulation and antiplatelet therapy demands a precision medicine approach. It requires ongoing risk reassessment and collaboration between cardiology, hematology, and interventional teams. The goal is clear: to maximize thrombotic protection while minimizing bleeding, ensuring each patient receives the safest and most effective regimen tailored to their needs.